Welcome to A4 Medicine. This is your host Rahul Srivastav. This video covers multiple sclerosis in primary care, focusing on the NICE guideline. It's numbered NG220, the 2024 McDonald criteria, and the GP role in long-term care. MS diagnosis is specialist-led, but the primary care is vital for recognition, referral, symptom review, relapse, triage, and safety. Multiple sclerosis or MS is an inflammatory condition of the brain and spinal cord. The immune system damages myelin, which is a protective covering around nerves. When myelin is damaged, the nerve signals slow or fail, causing symptoms such as visual loss, numbness, weakness, imbalance, bladder problems, fatigue, or memory difficulty. MS care is shared between primary care and the specialist neurology, with the patient at the center. Neurology confirms the diagnosis, arranges MRI, specialist tests, and leads disease modifying treatment. Primary care supports recognition, annual review, infection, screening symptoms, management, prescribing safety, mental health, and coordination. This slide focuses on that. And in summary, the GP does not diagnose MS alone. The GP recognizes, refers, reviews, and coordinates. When you suspect MS, when symptoms suggest a problem in the optic nerve, brain, or spinal cord. Key red flags include painful loss of vision in one eye, double vision, ascending numbness or weakness, and worsening gait or balance. Lhermitte sign means an electric shock like feeling down the spine or limbs when bending the neck forward. And so, focal neurology lasting over 24 hours without infection should raise suspicion. In primary care, first decide whether this sounds like a true neurological episode. Take a clear history, examine the nervous system, and exclude common mimics such as infection, migraine, vitamin B12 deficiency, stroke, or functional symptoms. If MS is suspected, refer to consultant neurologist. So, in primary care, we do not diagnose MS from MRI alone, refer suspected MS to neurology. The McDonald criteria are the specialist rules neurologists use to diagnose MS. They look for dissemination in space and dissemination in time. Dissemination in space means lesions in different parts of the CNS. Dissemination in time means evidence that disease activity has occurred at different times. In the 2024 criteria, the optic nerve is now included as a fifth CNS site, and dissemination in time is no longer always an absolute requirement in selected high specificity situations. Know the DIS and DIT for exams, but applying McDonald criteria is a specialist work left to specialist consultant neurologists. The annual review is a major primary care opportunity. Ask about mobility, falls, hand function, tremor, fatigue, pain, bladder, bowel, sexual function, mood, sleep, cognition, medicines, bone health, and social support. Many MS symptoms are not volunteered unless asked directly. Use a checklist or for and include mobility, mood, bladder, bowel, pain, fatigue, cognition, and bone health. There are three practical messages here. First, advise smoking cessation because smoking is linked with worse MS outcomes. Second, encourage exercise. NICE advises that regular exercise may help and it does not harm MS. Third, correct vitamin D deficiency if present, but do not offer vitamin D solely to treat MS. So, in practice, remember to stop smoking. Advise to stop smoking, stay active, and correct any deficiency, particularly vitamin D, but avoid over promising. Bladder, bowel, and sexual symptoms are common in MS, but patients may not mention them. Ask directly and sensitively. A useful phrase is some people with MS have bladder, bowel, or sexual symptoms. Is this something that affects you? If symptoms worsen, consider UTI, constipation, retention, or medication effects. Fatigue is common in MS, but do not assume it always caused by MS. Check for sleep problems, infection, anemia, thyroid disease, depression, pain, bladder symptoms, and medication side effects. For memory or concentration problems, also consider mood, sleep, fatigue, and medicine. So, fatigue workup includes inquiry about sleep, mood, infection, anemia, thyroid, and medicines. Non-drug management comes first: pacing, energy conservation, sleep routine, exercise, and CBT style strategies. If medication is considered, NICE lists amantadine, modafinil, or an SSRI as possible specialist led options using shared decision making. These are off label, and modafinil needs particular caution in pregnancy or if pregnancy is planned. Remember the do nots, which is do not offer B12 injections or hyperbaric oxygen for MS fatigue. Spasticity means increased muscle tone or stiffness. Before prescribing, look for triggers such as UTI, constipation, pain, pressure sores, or poor positioning. Baclofen is usually considered first line when there are clear goals such as improving mobility or reducing pain. Gabapentin may be considered if baclofen is not tolerated or inadequate. Before increasing muscle relaxants, always ask what is triggering the spasticity. The key safety message is never stop baclofen suddenly. Abrupt withdrawal can cause severe rebound stiffness, confusion, hallucinations, seizure, or delirium. If stopping, reduce gradually. Be cautious when combining baclofen and gabapentin because both can cause sedation and increase respiratory risk. Pain in MS should be managed by cause. Musculoskeletal pain may come from immobility, posture, or spasticity. Neuropathic pain is nerve pain, often burning, shooting, electric, or tingling, and should always be managed using neuropathic pain guidance. For cognition, ask about memory, concentration, work, and daily function. A true MS relapse means new or worsening neurological symptoms lasting more than 24 hours after at least 1 month of stability with no infection or other cause. A pseudo-relapse is temporary worsening caused by infection, fever, heat, or physiological stress. The commonest primary care trap is missing infection. So, in practice, before calling it a relapse, check for UTI, chest infection, fever, and recent illness. When a patient with MS presents with worsening symptoms, split the pathway. If they have urinary symptoms, cough, fever, or systemic illness, treat the underlying infection first. If symptoms are focal, disabling, last over 24 hours, and there is no infection, discuss the relapse pathway with the MS team. So, in practice, do not rush to steroids until infection has been excluded. NICE advises treating relapses that affect usual activities as early as possible and within 14 days of onset. Non specialists should discuss both the diagnosis of relapse and whether steroids are needed with an MS specialist because not all relapses require steroids. If treatment is appropriate, use oral methylprednisolone 500 milligrams daily for 5 days. Remember three high yield areas. First, driving. Patients with MS must tell the DVLA. Car and motorcycle drivers can report online or use Form CN1, and failure to notify can lead to a fine of up to £1,000. Second, pregnancy. Relapse rates often fall during pregnancy, especially in the third trimester, but increase in the first 3 months after birth. So involve the MS team early. Third, mental health, depression is common. Around half of patients may experience it over a lifetime, and suicide risk is about twice that of general population. So screen proactively. So in summary, DVLA, Form CN1, postpartum relapse risk, and proactive mental health screening. Good MS care is coordinated care. The patient may need neurology, an MS nurse, physiotherapy, occupational therapy, continence services, mental health support, and a social care. The GP helps connect the network, picks up deterioration, asks the hidden question, and ensures the right team is informed. So every patient should know who to contact, particularly the MS nurse, and if when the symptoms worsen. Disease modifying therapies or DMTs are specialist drugs that reduce MS disease activity or relapse risk. They're prescribed and monitored by specialist teams. The GP role is to inform the MS multidisciplinary team about relapses, infections, pregnancy plans, safety concerns, and major changes in symptoms because relapse frequency can change treatment decisions. So, after any relapse, tell the MS team DMT decisions may depend on relapse frequency. Thank you for watching this A4 Medicine primary care presentation. The key message is simple: recognize MS, refer appropriately, exclude infection during deterioration, use steroids carefully, and keep the MS teams informed. I put down the top five primary care takeaways here for you, which hopefully will help you manage this condition in primary care in practice much more efficiently. Thank you for watching. Please subscribe to our channel. Please like and share this video. It helps us grow, and we keep bringing more useful contents for you. And for further MCQs and books, visit our website for medicine, please. Thank you.